Now we're going to see the disease intravascular coagulation. The disseminated intravascular coagulation is thrombosis, and bleeding. Usually we see it as bleeding, as an emergency of bleeding, but we could also see thrombosis. So the pathogenesis is there is something that activates the coagulation cascade, and this activation in the coagulation cascade leads to production of thrombi. The thrombi are made of platelets and coagulation factors. So all the time the patient is forming clots, but also when the patient now needs platelets and coagulation factors in order to produce the clot. For example, let's say that the patient is in the hospital and in the puncture sites are bleeding. This bleeding is due to the consumption of platelets and coagulation factors that are not enough to go to the place in which they are needed, because this is a consumption coagulopathy, because the patient first formed thrombi just like that. There was no bleeding, and now that there is bleeding, the consumption is the coagulation factors and the platelets are consumed. So the patient is bleeding and has thrombosis. Now, in the acute presentation, the main concern is bleeding. The patient is bleeding from the puncture site, and sometimes the patient can be in shock, so we will need to treat the shock. And the treatment, the acute treatment, would be transfusion of platelets, plus fresh frozen plasma that contains the coagulation factors, and sometimes, if this fails, we give cryoprecipitate because we want the fibrinogen. Now, in acute is bleeding the main concern. In chronic, the patient can present as either bleeding or thrombosis. Bleeding would be more superficial, for example, mucosal bleeding, but the patient can also present with thrombosis. The thrombosis could be profound, deep thrombosis, that would be deep vein thrombosis, for example, and then a pulmonary embolism, or could be superficial. The superficial thrombosis would be a thrombophlebitis. The thrombophlebitis presents as a painful hot cord nodule. The patient should be started on heparin only if there is thrombosis. So certainly if the patient is bleeding, we do this. We're not going to give heparin. Heparin would promote the bleeding. So only if the patient has thrombosis, we would give heparin. Now, the causes of disseminated intravascular coagulopathy are many causes. We have sepsis. Sepsis usually Escherichia coli or Neisseria. Well, these bacteria produce endotoxins, and the endotoxins activate the lymphocytes and release cytokines. These cytokines would be interferon, for example, interferon or IL-1, and this activates the coagulation cascade. Also, if there is trauma, severe trauma, for example, head trauma, or like that, there will be release of tisular factor, and this activates the coagulation cascade. Rhabdomyolysis increase or activate the coagulation cascade. The venom of the snake, of some snakes. Pancreatitis, the release of the enzymes in pancreatitis activates coagulation factors. Pancreatitis, the acute respiratory distress syndrome, a large aortic aneurysm, amniotic fluid embolism, This could be a complication. Is a obstetrical complication, could be abruption placenta, or could be just in a normal pregnancy. But the issue is that the tisular factor of the placenta would activate the coagulation cascade, and also the amniotic fluid that contains the tisular factor will activate the coagulation cascade. Sometimes the patient can present with the amniotic fluid embolism and the disseminated intravascular coagulopathy. And the other is a heat stroke. In the heat stroke, the patient has decreased dissipation of the heat, and so this leads to severe hyperthermia, and this increases the oxygen and metabolic demand and rate, and this shunts the blood from central organs, so away of central organs, to the skin. And so the skin is receiving a lot of blood, and this would release tisular factor. And so there would be activation of the coagulation cascade and would lead to the disseminated intravascular coagulopathy. This is a severe disease, it's a emergency, and we need to treat it. Usually in the acute setting would be the bleeding the main concern, and we should treat with platelet transfusion, fresh frozen plasma, and if this doesn't work, we go to the cryoprecipitate due to the fibrinogen, and we need to manage the shock as needed.